The GIANT study is really the first trial that focused on the vulnerable older patients with metastatic pancreatic cancer. This is the first time we're conducting an elderly-specific trial in metastatic pancreatic cancer, which is really important because the majority of patients with pancreas cancer are older. The median age is 70, and these are very, very common situations that we face in clinic. But what we did in the GIANT study is we focused on the vulnerable patients within that group. So, the people that really pose a very big clinical challenge. Do you give them chemo? How much chemo do we give them? And what factors can we identify to help us decide who gets chemo and who doesn't, and who benefits from chemo and who would actually have detrimental consequences from chemotherapy? So in this trial, we had identified those individuals based on three factors: their function, their cognition, and their comorbidities. And any vulnerability within those criteria qualified the patient for the trial. In addition, if a patient was over the age of 80, they automatically were candidates for this trial. And every patient underwent a full geriatric assessment, evaluating all the domains that could affect their care, as well as quality of life evaluation at baseline before getting randomized. And then they were randomized to one of two treatment arms that were dose-reduced chemotherapy. The control arm was gemcitabine and nab-paclitaxel, given every other week. And the experimental arm was 5-FU and liposomal irinotecan, given a dose reduction every other week. We followed these patients for overall survival. That was our primary endpoint. But a secondary endpoint was looking at these baseline markers, because we wanted to understand which patients really should receive chemo and would benefit from it. And what I presented at this meeting is that analysis looking at the baseline factors. The primary analysis was presented at ASCO, but in this meeting, we focused on these geriatric factors and the quality of life measures. And what we found is that there were clear trends that predicted outcomes. Function was one of them. So through evaluating IADLs, instrumental activities of daily living, we could identify patients who were at risk for having poor outcomes. Nutrition was a big factor, and depression. Similarly, patient with depression had poor outcome, patient with poor nutritional status had poor outcome. And then looking at quality of life measures, every single one of the quality of life tools that we used clearly identify patients that would do poorly. So if your quality of life scores at baseline were low, you had a lower chance of having good overall survival. So that brings us to think that really how patients present at baseline could be a way for us to identify those who could benefit from chemo in this vulnerable patient population, but also potentially identify areas that we can intervene, that we can improve supportive care measures, that we can address geriatric abnormalities and vulnerabilities, and maybe through supporting patients at baseline, we can improve their outcomes from treatment. We found no difference between the arms. And there was no difference between the arms in terms of survival. There was no difference between the arms in terms of toxicity. Overall, the rate of grade 3 or higher toxicity was the same in both arms. The agents are different, right? So with gemcitabine and nab-paclitaxel, you will get more neuropathy. With 5-FU and liposomal irinotecan, you may get more GI symptoms. The regimen is different in terms of schedule, in terms of delivery. So I think that what this data helps us is that we now have two treatment options that fare about the same. And if we identify patients that do benefit from chemo and we want to try chemo, we can find the treatment that would be appropriate for them based on side effects, schedule, and way of delivery. This study, first and foremost, provides the oncologist with data that can inform decision-making for patients and for caregivers, understanding what the true outcomes are for this vulnerable patient population can inform the conversation. So if an oncologist sees a patient that has poor performance status, has very some challenges with nutrition, potentially some functional challenges, and maybe other quality of life measures that are not well supported. And we have here prospective data that those patients are not going to fare well with chemotherapy. And you can have a very open and informative discussion with the patient and the family of what benefit that patient may receive from chemo and what detrimental effect you may have from it. So I think that is a really important information that we derive from this trial. On the flip side, we also see that those patients who are a little bit at better performance status or have more support or have less geriatric abnormalities affecting their care fare better and may derive benefit from chemo. And in that setting, you have the data to really discuss with the patient what benefit they can have. One analysis that we conducted in this trial, which I think is really important to drive this point, is that when we looked at patients that were able to receive more than 1 month of therapy, that was about 70% of our population, those patients had a median overall survival of 8 months. And that's in line with what we saw with standard chemotherapy doses. So clearly there are patients who can derive benefit with a lower dose of chemo, but we have to do a better job at identifying them. And hopefully the geriatric factors at baseline can help us do a good job at understanding who should receive therapy and who shouldn't. I will just add that I think this was a huge effort to have an elderly-specific clinical trial in pancreas cancer. I think the trial demonstrates how much important data we are deriving from this effort, and I hope that this will encourage more trials in this very prevalent and growing patient populations in our clinic.